Hello everyone, I am myself Dr. Rajesh Gubba. In this particular session, I'll be discussing the very important cardiac emergency, that is cardiac tamponade. So first and foremost, let me just give you quick overview of what will be the presentation of these patients with the cardiac tamponade. So definitely it is one of the very important cardiac emergency where the patient will present with sudden onset severe form of dyspnea, right? That will be the clinical presentation. Now, if you take the differential diagnosis for sudden onset dyspnea of cardiac origin, right, it would be acute left ventricular failure, right, where it will cause the pulmonary edema. And even this cardiac tamponade, it will also cause sudden onset severe form of dyspnea. And how is that you will make a quick diagnosis of the cardiac tamponade is, one is the characteristic pulse, that is paradoxical pulse will be there, and the JVP is elevated but Kussmaul sign will be absent. And the other very important is the Beck's triad, where the individual will have the hypotension, then the heart sounds will be muffled, and there will be jugular venous distension. And then how will you diagnose? The very important quick method of diagnosis is by two-dimensional echocardiography. And ECG will show you the electrical alternance and all, but the quick and the best method of diagnosing cardiac tamponade is by 2D echo. Then how do you treat? Remember, the treatment of choice in these patients with the cardiac tamponade will be pericardiocentesis. That will be the treatment of choice. So this is a quick review of the cardiac tamponade. So now let me just discuss like what will be the overview of the topic which I'll be doing a detailed discussion on. So I'll be discussing the basic anatomy and physiology of the pericardium, what exactly are the pericardial functions. Then I'll be discussing the two important physiological aspects, that is tension stretch relationship and as well as the pressure volume relationship of the pericardium and as well as the cardiac chambers. Then what exactly is the difference between the cardiac tamponade and pericardial effusion? What exactly are the various etiologies that will be causing cardiac tamponade? Then what exactly is the pathogenesis for the development of sudden onset dyspnea in these patients with the cardiac tamponade? What will be the clinical features and how will you diagnose cardiac tamponade and how do you treat the cardiac tamponade? So this will be the overview of the topic, right? Now let us start the discussion with the basic anatomy of the pericardium. So if you take the pericardium, like you have the fibrous pericardium. This fibrous pericardium, it is the outer layer of the pericardium, and then you have the serous pericardium, which is the inner layer. For this serous pericardium, you have two layers, right? What are those two layers of the serous pericardium? That includes the parietal serous pericardium and the other one is the visceral serous pericardium. So these are the two layers of the serous pericardium, parietal serous pericardium and then visceral serous pericardium. Now let me give you detailed discussion about this fibrous and as well as the serous pericardium. So if you take the fibrous pericardium, you see here, this is the fibrous pericardium. So this fibrous pericardium, remember, it is the outermost layer of the pericardium, right? And this fibrous pericardium, it is composed of connective tissue, right? It is composed of the connective tissue, right? And what will be the thickness of this fibrous pericardium or the fibrous outer layer? The thickness, it is around 2 millimeters in thickness, right? And this fibrous pericardium, it is acellular, okay? It doesn't have the cells. Then what is it composed of? It is composed of the collagen and as well as the elastin fibers. Okay, so these are the components of the fibrous pericardium, right? And this particular collagen being the important structural component, right? Out of this collagen and elastin fibers, the collagen being the important or major structural component, right? Collagen being the major structural component. Now, if you take this fibrous pericardium, it has the attachments, okay? So fibrous pericardium, it has the attachments to the diaphragm. Fibrous pericardium, it also has the attachments to the great vessels, right? So what are these great vessels? The great vessels, that is aorta from the left ventricle, pulmonary artery from the right ventricle. So this fibrous pericardium, it has the attachments to the diaphragm and as well as the great vessels that are going out of the heart and great vessels entering into the heart. Even it has the attachments to the superior and as well as the inferior vena cava, right? And this parietal pericardium, that is your fibrous pericardium, if you take the attachments, they are the ligamentous attachments, right? And this ligamentous attachments of this fibrous pericardium is to the diaphragm, right? And it has the ligamentous attachment to the sternum and the other structures. That is about the ligamentous attachment of the fibrous pericardium. Now, what is the importance of these particular attachments? The importance of the attachments is that these attachments ensure that the heart, it occupies a fixed position within the thoracic cavity. That is the importance of this ligamentous attachment of the fibrous pericardium to the diaphragm and as well as the sternum. Now, followed by that, we have the serous pericardium. So serous pericardium, like I said you, we have two layers, right? What are those two layers? One is the parietal layer and the another one is the serous layer, okay? So this is the serous layer of serous pericardium. So you have parietal serous pericardium and then you have visceral serous pericardium. Now, in between this parietal serous pericardium and visceral serous pericardium, you have the presence of the fluid, right? So where exactly is the fluid present? The fluid is present between the parietal serous pericardium and as well as the visceral serous pericardium, all right? Now, what will be the quantity of the fluid? And if you take this parietal serous pericardium, it is in close attachment to the fibrous pericardium, right? It is very closely attached to the fibrous pericardium. Whereas if you take the serous pericardium, right, that is visceral serous pericardium, right? If you see the visceral serous pericardium, it is in very close attachment to the epicardium, right? It is very close attachment to the epicardium. You can see that this is the epicardium, okay? So the visceral serous pericardium, it is in very close attachment to the epicardium, right? Now that means it is in close contact with the heart. Now if you take this visceral serous pericardium, it is having a single layer of mesothelial cells, okay? It has monolayer of mesothelial cells, right? Along with that, it also contains the collagen, right? Along with the monolayer of mesothelial cells, there is also the collagen and as well as the elastin fibers, right? Collagen and as well as elastin fibers that are being attached to the epicardial surface of the heart. You see, this is the epicardial surface, okay? Now in the pericardial space, where is your pericardial space now? That is in between parietal serous pericardium and visceral serous pericardium. You have the pericardial space, that is pericardial sac. Now this pericardial sac, it contains the fluid. And how much is the fluid? It is nearly around 50 ml of the fluid. And this particular fluid, the normal fluid, it is serous in consistency, right? Now after having discussed about the basic anatomy, now let me discuss about the function of this pericardial fluid or the function of the pericardium, right? So if you see the functions, first and foremost, the pericardium is the one which will maintain the position of the heart, okay? Because of its attachments, ligamentous attachments with the fibrous pericardium to the diaphragm and as well as the sternum, the pericardium will maintain the appropriate position of the heart within the thoracic cavity. And this pericardium, it also provides barrier to the infection, okay? So that the external infectious organisms from the thoracic cavity will not enter into the heart. So thereby it will protect the heart. Now you take the function of the pericardial fluid. The function of the pericardial fluid is it will act as the lubrication between the parietal serous pericardium and visceral serous pericardium. So it is having the lubricating function, and this particular pericardium, it is innervated by a good number of receptors. Now what are these receptors? These receptors are: number 1, mechanoreceptors; number 2, chemoreceptors; then we have phrenic afferent receptors. Okay, so these are the receptors, they are present within the pericardium. And what is the importance of these receptors? They participate in the reflexes which are arising within the pericardium or the epicardium. One of the example of the reflex is the Bezos-Jaris reflex, right? And these particular receptors which are present within the pericardium, they play an important role in these reflexes. Okay, now what are the other important functions, right? The pericardium, it also helps in the transmission of the pericardial pain. So thereby it tells that there is some pathology which is undergoing within the pericardium. And this pericardium, it also secretes the prostaglandins, right? And what is the role of the prostaglandins which are secreted by the pericardium? They modulate the neural traffic, and not only that, they also maintain the coronary tone. Because if you take this coronaries, right, the coronaries are present on the epicardium in attachment with your pericardium. So the prostaglandins which are released by your pericardium, they helps in maintaining the neural traffic and as well as the coronary tone. So this is about the functions of the pericardium. Now let me just go back. So whatever we have discussed now is the basic anatomy of the pericardium. Now let me discuss the physiology of the pericardium, that is the tensile stretch relationship and as well as the pressure volume relationship of the pericardium with its chambers. Now if you see this graph, so this is a graph which is telling you about, so on the y-axis you have the tension which is developed within the pericardium, and the x-axis, it tells you about the stretch of the pericardium. Okay, so basically what does this particular relationship tells you, right? That tells you the mechanical function of the pericardium, right? It tells you the mechanical function of the pericardium. So what is that mechanical function? The pericardium says that it has the restraining effect, right? It says that the pericardium has the restraining effect on the cardiac volume. So in nutshell, what does it mean is, it will not allow, the pericardium will not allow the excessive dilatation of the cardiac chambers because of the excessive inflow of the blood, right? Once the inflow of the blood has reached to the maximum, then further stretch of the pericardium does not occur. So it has the restraining effect on the cardiac volume, right? So this reflects what? This reflects the mechanical properties of the heart. That is what we were discussing above also. So mechanical function that reflects the mechanical properties of this pericardial tissue, right? Now out of which you take this, the parietal pericardium. Parietal pericardium, right? What is the nature of the parietal pericardium? It has a tensile strength, and the tensile strength of the parietal pericardium, it is similar to that of a rubber, right? It is similar to that of a rubber. So what does it tells you is, if suppose if there is a low stretch or low stress, right? If there is a low stress on the pericardium, if there is low stress, remember the pericardium is very elastic, right? The pericardium is very elastic when there is low stress, but as the stretch increases, right, as the stretch increases, what happens? The tissue abruptly it becomes stiff, right? The pericardium, that is the tissue, it becomes abruptly stiff and resistant to the further stretch, right? And resistant to further stretch. Okay, that is what the mechanical property of the pericardium says, right? When there is a low stress on the pericardium, it is having that elastic nature, but as the stretch increases, the tissue abruptly it becomes stiff and it will further resist the further stretch. Okay, now what it says is, now you can just see even within the graph also. So as the stretch is increasing, gradually the tension within the pericardium is also increasing, but once the stretch has reached maximum, right, once the stretch has reached the maximum, further expansion of the pericardium does not occur and there will be progressive increase in the tension within the pericardium. So this particular point, okay, this particular point, right, this particular point, the red mark what I have drawn here, this point on the stress strain relationship, this says that this is a transition point. Okay, so this is the transition point. So transition point for what, right? So this is a transition point that corresponds to stresses near the upper range of the physiological cardiac volume. That means this particular transition point tells that the cardiac volume whatever has entered into the ventricle, that is maximum, right? Further entry of the cardiac volume is not permitted. Okay, so at this particular transition point, remember, the heart has achieved the upper range of the physiological cardiac volume, beyond which the pericardium does not allow. That is what is your tension stretch relationship, right? Next to that, so this is your tension and stretch. So stretches for the pericardium, tension which is developed within the pericardium, and the next one is the pressure volume relationship of the pericardial sac. So if you take the pressure volume relationship, this is also almost the same. You see here on the x-axis you have the volume and on the y-axis you have the pressure. Okay, now as the volume is entering into the ventricle, right, so you see here the volume it is increasing, then what will happen to the pressure within the pericardium? The pressure within the pericardium it increases, right? And the relationship between the volume entering into the ventricle and the pressure which is developing within the pericardial space, that is what is nothing but your pericardial volume relationship, that we call it as the PVR, right? That we call it as the PVR. Now let me tell you the important points here. The pressure volume relationship of the pericardial sac, it parallels the property of isolated parietal pericardial tissue, that is, it is flat, compliant segment transitioning relatively bit abruptly to a non-compliant segment. That means again, for this also you have a transition point, you know, this is the transition point, right? So at this particular transition point, further entry of the volume of the blood into the ventricle cannot occur, right? So this is the maximal volume, and beyond which only the pressure increases but the volume does not increase. Okay, so this tells at this point, this part of the pericardium it is compliant, right? It's a compliant pericardium, and this part of the pericardium it tells it is the non-compliant pericardium, right? Because the pressure within the pericardial space has abruptly increased to maximum, right? So further entry of the volume of the blood into the ventricle does not occur. So how does the sac behave as the pericardial sac? Thus the sac has relatively small reserve volume, right? What it says is when this particular small reserve volume is exceeded, right? When the reserve volume is exceeded, the pressure within the sac operating on the surface of the heart increases rapidly and it is transmitted to the inside of the cardiac chambers. That means the pressure which has been elevated within the pericardial space, that will be exerted into the cardiac chambers. So thereby what will happen now? Thereby further stretch of the cardiac chambers does not occur. Okay, so that is what is your pressure volume relationship. So one is your tension stretch, the other one is pressure volume. So this is the basic physiology. Now first of all, let us understand how much is the normal intracardiac pressure, right? And how much is the normal intrapericardial pressure. Both of that let us try to discuss. Okay, so if you take the normal right atrial pressure, right, it is around 0 to 8 millimeters of mercury, right? That means during the systole it will be up to 8, during the diastole it goes up to 0, right? Whereas you take the right ventricular pressure. Okay, so if you take the right ventricular pressure during the systole of the right ventricle, right, the pressure it goes up to 15 to 30 millimeters of mercury, whereas during diastole the pressure will be up to 8 millimeters of mercury, right? That means during the diastole the pressure can go even up to 0 also, right? Next, whereas you take the left atrium, the pressure is around 4 to 12 millimeters of mercury. What does that mean? 4 will be the pressure during the diastole of the left atrium, 12 will be the pressure during the systole of the left atrium. And similarly you take the left ventricle during the systole, the pressure it goes up to is 90 to 140 millimeters of mercury. During the diastole, the left ventricular pressure will be around 5 to 12 millimeters of mercury, right? 5 to 12 millimeters of mercury. And at the same time, let us try to discuss even in the great vessels also. So if you take the great vessels are like pulmonary artery from the right ventricle, aorta from the left ventricle. You take in the pulmonary artery. In the pulmonary artery, during the systole, the pressure is up to 15 to 25 millimeters of mercury, right? Whereas during the diastole, in the pulmonary artery, the pressure is around 5 to 15 millimeters of mercury, right? Then you take in the aorta. So during the systole, the pressure will be up to 90 to 140 millimeters of mercury, and during the diastole it will be around 60 to 90 millimeters of mercury during the diastole, right? So this is about your normal chamber pressures during the systole and diastole, and as well as even within the great vessels. Now why is that we are discussing this? Because I want to explain to you what will happen in the cardiac tamponade, right? What will happen to the pericardial pressure within the cardiac tamponade? That is what I wanted to discuss. All right, so after having said about the normal intracardiac pressures, that is in all the 4 chambers, now if you see like what will be the normal intrapericardial pressure, right? So that is within the pericardial sac. What is the normal intrapericardial pressure? The normal intrapericardial pressure, it is -3 to +8 millimeters of mercury, right? So during diastole it will be like -3, and during systole it will be up to 8 millimeters of mercury. That is the normal intrapericardial pressure. Now, so with this basic idea of the pressures within the chambers and within the pericardium, now we will try to discuss what will happen to the pressure changes within the cardiac tamponade. So if you take in case of the cardiac tamponade, in cardiac tamponade, you know, the intrapericardial pressure, which was like -3 to +8, it will be around 15 millimeters of mercury. In severe cases, it may go even up to 25 millimeters of mercury, right? It goes from 15 to 25 millimeters of mercury in case of the cardiac tamponade. Similarly, let us also try to discuss like what will be the pressure changes within the chambers of the heart. Now you see, now you have to understand it very clearly here. So what has happened to the intrapericardial pressure? The intrapericardial pressure is elevated. Now once the intrapericardial pressure is elevated, now these particular chambers of the heart, if they want to relax, what should happen to the pressures within the chambers of the heart? It should also increase. Then only they can relax. You have to understand this concept, right? The concept is that the intrapericardial pressure is elevated in cardiac tamponade from 15 to 25, right? In severe cases, it can go up to 25 millimeters of mercury also. So now if you take these cardiac chambers, like what are their pressures during the diastole, right? So if you take their pressures during the diastole, right, within the right atrium, it can go even up to 0 also, right? Within the right ventricle, the pressure is up to 15. And in the left atrium, during diastole, it is 4. In the left ventricle, the pressure is during diastole is 5 to 12 millimeters of mercury. Now, is this pressure sufficient for the cardiac chambers to relax in cardiac tamponade? No, because in cardiac tamponade, the pressures are like increased 15 to 25 millimeters of mercury. So that is the reason why, in order to accommodate that increased intrapericardial pressure, the pressure within the cardiac chambers are also elevated in order to relax. Okay. Now, so you take within the right atrium, the pressure which is elevated within the right atrium is up to 15 millimeters of mercury, right? And how much was the normal? Right, the normal was 0 to 8 millimeters of mercury, but the pressure within the right atrium is elevated up to 15. Why is it elevated? I'll tell you. Because in the right ventricle, during the diastole, how much is the pressure during the diastole? It is 0 to 8 millimeters of mercury during the diastole of the right ventricle. But in cardiac tamponade, the pressure, it goes up to 10 millimeters of mercury. Right? How much is the normal? Normal is 8. How much is it increased? It is increased to 10 millimeters of mercury. Why? Because if right ventricle has to relax, it has to increase its pressure, because surrounding that, the pericardial pressure is also elevated. Now, because the right ventricular pressure is very high, now your right atrium, in order to send the blood into your right ventricle, what the right atrium has to do? Right atrium also has to increase its pressure to send the blood into right ventricle. So that is the reason why the pressure within the right atrium has increased up to 15 millimeters of mercury, right, during the diastole of your right ventricle. Now, you take the left atrium. Now, in the left atrium, you know how much will be the pressure that will be elevated in the left atrium? The pressure that will be elevated is up to 20 millimeters of mercury, whereas left ventricle, during the diastole, the pressure which will be elevated is up to 30 millimeters of mercury. How much is the normal diastolic pressure within the ventricle? The normal diastolic pressure within the ventricle is 5 to 12. But why it is increased up to 30 in left ventricle? Because left ventricle has to relax against increased pericardial pressure. So it is increased up to 30. Now, once the diastolic pressure within the left ventricle is increased up to 30, now if the left atrium has to send the blood into the left ventricle, even the left atrial pressure also has to be elevated, and that will be elevated up to 20 millimeters of mercury, right? Now, the point that you have to understand here is the pressure rise whichever is elevated in your atria may not be sufficient to send the blood into your ventricles, right? Now, subsequently in the pathology or pathophysiology, I'll discuss what will happen. But the pressure changes you have to understand here, that in the normal chambers and normal pericardium, these are the pressures, right? And in the cardiac tamponade, these are the pressure changes. With this basic idea, we will go ahead with like what is cardiac tamponade, what is the pathogenesis, all that we will discuss now. So, if you take the cardiac tamponade, what is the basic definition of it, right? So, it is a scenario where there is abrupt accumulation of the fluid in the pericardial space, right? And because of abrupt accumulation of the fluid in the pericardial space, the pericardial pressure, it rapidly increased. And because the pericardial pressure is rapidly increased, this will lead to a serious condition. What is that serious condition? That is, there will be obstruction of the inflow of the blood into ventricles, right? Into ventricles from the atria, right? From the atria. So that is the basic definition. So In patients with cardiac tamponade, the accumulation of the fluid in the pericardial space in a quantity which is sufficient to cause a very serious obstruction of the inflow of the blood from atria to the ventricles, that is what is your cardiac tamponade. So why is that there is an obstruction to the inflow of the blood? Because the pericardial pressure is elevated and ventricles are unable to relax, and that is the reason why atria is unable to send the blood. That is what is nothing but the obstruction of inflow of the blood into the ventricle, right? And as such, remember, this cardiac tamponade, it is very fatal condition. You have to recognize it early and you have to treat it promptly. Otherwise, the individual can have a sudden cardiac death, right? So if you take the etiology of the cardiac tamponade, the most common cause of the cardiac tamponade are, number one, the idiopathic pericarditis. We don't know what exactly is the cause, right? Idiopathic pericarditis is one of the clinical scenario, and this idiopathic pericarditis, most commonly it could be of the viral origin, right? That could be your Coxsackie virus or the ecovirus. And then we have some neoplastic diseases that can cause cardiac tamponade. So in this neoplastic diseases, we have the primary tumors, and these primary cardiac tumors include the myxomas. Myxomas, they can cause the cardiac tamponade. But remember, these myxomas, they are the benign tumors, right? But when these myxomas, they grow large enough, then they can cause the cardiac tamponade. Then we have metastatic tumors that can cause the cardiac tamponade, and this metastasis to the heart, it is from the bronchogenic carcinoma, that is lung cancer. This could be from the breast carcinoma. This could be from the melanoma. Okay, so metastatic tumors, right, they also contribute for the development of the cardiac tamponade. Then the another malignancies are the hematological malignancies, right? The hematological malignancies. So if you take this hematological malignancies, the blood cancers that can cause cardiac tamponade include lymphoma, right, and leukemia, right? Lymphoma and as well as the leukemia, they can also cause the cardiac tamponade. Then followed by that, the tumor of the serous cells or the serous cavities, right? What is that tumor? That is nothing but mesothelioma. Okay, so mesothelioma, it's a tumor which is originating from the pleura or from the pericardium itself, that can cause the cardiac tamponade, right? Then we have some infections which can cause cardiac tamponade, and very, very important infection, mainly in developing countries like India, that will be the tuberculosis, right? And bleeding into the pericardial sac can also cause cardiac tamponade, that can occur as the part of the aortic dissection, right? That can occur as a part of the aortic dissection. And that bleeding into the pericardial sac can also occur in trauma. Bleeding into the pericardial sac can also occur during any of the cardiac surgery, right? And the bleeding into the pericardial sac can also occur when the patient is taking the treatment with anticoagulants. They also can cause the cardiac tamponade, right? Now, so these are all the etiologies causing cardiac tamponade. So these etiologies we have discussed, that is the cardiac operation, trauma, and treatment with anticoagulants. Next is the pathogenesis in patients with the cardiac tamponade. So you have to remember two important things. One, there is diastolic dysfunction. Then there is diastolic collapse of the ventricles. Okay, now why is that there is diastolic dysfunction? So if you observe here, the pericardial space, the pressure is increased, right? Within the pericardial space, once the pressure is increased, now tell me, the ventricles, can they relax? No, they cannot, because the pressure within the pericardium is high. So that is the reason why these particular ventricles, they cannot relax. Okay, so that we call it as the diastolic dysfunction. Now, once there is diastolic dysfunction, what will happen to the diastolic pressures of the ventricle? The diastolic pressures of the ventricles, they increase. Okay, now once the diastolic pressures of the ventricles increase, now atria, do they send the blood comfortably into the ventricle? No. So thereby what will happen is there can be also increase in the pressure even within the atria. That is, the left atrial pressure is elevated and even the right atrial pressure is elevated. Both RA and as well as the LA pressure is being elevated. Now, the RA pressure, right, the RA pressure which is being elevated, that will be reflected to the jugular vein and that will result in the jugular venous distension, right? That will result in jugular venous distension. Now, the another very important point is that during inspiration, the venous return has to increase, right? Venous return has to increase, but the right atrial pressure is already elevated and right atrium is unable to send the blood into the right ventricle because the right ventricular diastolic pressure is elevated, right? Okay, so right atrium is unable to send the blood into the right ventricle. Now, your venous return during inspiration, will it increase or will not increase in cardiac tamponade? You have to understand this very important concept that during inspiration, the venous return, it increases in case of the cardiac tamponade. How is it possible? How is it possible is because, you see, what will happen is, as the pressure within the right ventricle increases, what the right ventricular increased pressure do is, it will cause or it will exert that increased pressure on the interventricular septum, right? Now, the interventricular septum, it is shifted onto the LV lumen. So, thereby, right, so what will happen is, during inspiration, the venous return increases. So, during inspiration, what happens is, as the venous return increases, the right ventricular pressure is so much elevated that it shifts the interventricular septum towards the LV lumen, right, towards the LV lumen. So thereby, what will happen to the LV lumen volume? It decreases. Okay, the LV lumen volume, it decreases, right? Now you see, subsequently, further what will happen? Now your interventricular septum, it is being shifted to the LV. So as the interventricular septum is shifted to LV, the RV volume, it increases. As the RV volume is increased during inspiration, the blood, right, the blood from right atrium, it goes to the right ventricle and thereby the venous return increases, right? The concept is very simple. The RV volume is increasing because of the interventricular septum shift. So once the RV volume increases, the pressure falls and right atrium can comfortably send the blood into right ventricle and venous return to the right atrium increases during inspiration. So now thereby, the very important point is, do you have Kussmaul sign in cardiac tamponade? No. So Kussmaul sign is absent, right? Kussmaul sign is absent in case of cardiac tamponade. That is a very important point, right? Now, so even though your interventricular septum is being shifted onto the left side, what you have to understand during the diastole is, there is diastolic collapse of the right ventricle, right? So why? Because the intrapericardial pressure is elevated. That increased intrapericardial pressure is not allowing the ventricle to stretch maximally. So there can be also collapse of the right ventricle, right? Now, in the JVP, what are the important findings that you need to know now? So the JVP is elevated, but there is no Kussmaul sign. Very important point. Next, the another point that you should know is, you see, the interventricular septum is shifted onto the LV during the diastole. So now thereby, what will happen to the LV volume? That is reduced, right? So thereby, your LV end diastolic volume is also reduced. When your LV end diastolic volume is reduced, what will happen to your cardiac output during inspiration? During inspiration, the cardiac output decreases, right? That means during inspiration, the systolic blood pressure also decreases, right? During inspiration, the systolic blood pressure also decreases. Okay. And how much will be the decrease in systolic blood pressure? The decrease in systolic blood pressure will be more than 10 millimeters of mercury during inspiration, and that we call it as the pulsus paradoxus. Normally also there is a fall in the systolic blood pressure during inspiration. How much is that normal individual? In a normal individual, the fall will be less than 10 millimeters of mercury. But in cardiac tamponade, the fall is more than 10 millimeters of mercury because of the shift of the interventricular septum towards the LV, and thereby there is decrease in your LV lumen. Okay, right. Now, as the cardiac output is reduced, what is happening to your blood pressure now? There is hypotension, right? The another important pathophysiology that you need to know is there is lot of fluid surrounding the heart. When there is lot of fluid, right, when there is increased fluid surrounding the heart, what will happen to your heart sounds? The heart sounds, they become muffled, right? The heart sounds, they become muffled. So in the pathophysiology, what you have to understand here is that there is diastolic dysfunction, there is diastolic collapse of the ventricle. Next, there is pulsus paradoxus. Jugular vein is distended but Kussmaul sign is absent, and there is also hypotension, right? So that is what you have to understand in the pathophysiology. So that makes us to tell about a triad called as the Beck's triad in patients with the cardiac tamponade. So what is this Beck's triad? Number one, the hypotension. So why is this hypotension? Because the cardiac output is reduced. Why cardiac output is reduced? Because your LV and diastolic volume is reduced. Okay. Next, now there will be absent or muffled heart sounds. Why is that? Because of the increased fluid in the pericardial space that will reduce the transmission of the sounds to the surface of the chest. So once the transmission of the sounds to the surface of the chest is reduced, that will result in what is called as the absent heart sounds or the muffled heart sounds. Okay, right. And the next important thing is there is jugular venous distension, right? And this jugular venous distension, why is it occurring? Because right atrium is not in a proper position to receive the blood. Right atrial pressure is elevated, and that elevated right atrial pressure, right, that will be reflected to the jugular vein, and there will be jugular venous distension, right? Jugular venous distension. And in the JVP, you have some important abnormalities in the waves. What is that important abnormalities is they will have the prominent X descent. Why is that? I'll discuss. And there will be also absent Y wave, right? There will be absent Y wave. Now, why does this occur? Now, what does the X wave in JVP tells you? X wave in JVP tells you about the atrial relaxation. Now, in patients with the cardiac tamponade, what is your right atrial pressure? The right atrial pressure, you know, it is increased up to 15 millimeters of mercury. That means the stretch of the right atrium is maximum. That means it is maximally relaxing to its maximum consistency, and thereby you have the prominent X wave. X wave represents atrial relaxation, right? And there is a maximum stretch here, maximum relaxation. So that is the reason why you have prominent X wave. Then you take Y wave. Why is this particular Y wave absent? Y wave is absent because Y wave is due to what? It is due to atrial emptying. Now, is the atrial emptying occurring here? Not exactly, not properly. Why? Because in cardiac tamponade, there is diastolic collapse of the ventricle. Once there is diastolic collapse of the ventricle, you know, the flow of the blood from the atria to the ventricle does not occur properly, and that will result in the absent Y wave. Okay, that will result in the absent Y wave. Okay, now, after this, you should understand the difference between the cardiac tamponade and as well as the pericardial effusion. The difference is that the rapidity with which the fluid is accumulating. So, in case of cardiac tamponade, there is abrupt accumulation of fluid in pericardial space, right? Abrupt accumulation of the fluid in the pericardial space, and thereby there is rapid increase in the pericardial pressure. It can go up to 25 millimeters of mercury. So, And in pericardial effusion, the fluid which is accumulating within the pericardial space is, right, it is the gradual accumulation of the fluid in the pericardial space. Because it is a gradual accumulation of the fluid in the pericardial space, the pressure rise is also gradual. So what you have to understand here is, it is not the quantity of the fluid which will decide whether it is cardiac tamponade or pericardial effusion, right? It is not the quantity of the fluid. It is the rapidity with which the fluid is accumulating. Like for example, even to develop cardiac tamponade, even if 200 ml is accumulated, if it is rapid, then it can cause cardiac tamponade. Whereas in case of pericardial effusion, it might be even 2000 ml which is accumulated in the pericardial space. But if it is gradual accumulation, right, if it is gradual accumulation, remember, it will be pericardial effusion only, even though the fluid may be up to 2000 ml. So it is not the quantity which will decide whether it is cardiac tamponade or pericardial effusion. It is rapidity with which the fluid is accumulating will decide. Okay. When will you consider the diagnosis of the cardiac tamponade? The diagnosis should be considered in any patients whenever there is jugular venous distension, whenever there is hypotension, and whenever there is muffled heart sounds. Okay. And in the chest x-ray, you are finding that there is sudden enlargement of the cardiac silhouette. Then you have to suspect the cardiac tamponade, right? Now, if you take the clinical features in patients with the cardiac tamponade, very important point is sudden onset dyspnea, right? Sudden onset dyspnea. Multiple mechanisms are there why there is sudden onset dyspnea. The mechanism is that the pressure which is elevated within the pericardial space, that increased pericardial pressure will not only exert the pressure over the chambers of the heart, they will also exert the pressure on the surrounding lung parenchyma, right? When the pressure is exerted on the surrounding lung parenchyma also, the expansion of the lung parenchyma suddenly stops, and the behavior will be in such a way, the lung behavior will be in such a way that lung is collapsed. Actually, it is not a true collapse. But because of increase in your pericardial pressure, the pressure is exerted not only into the chambers, the pressure is also slightly exerted out of the chambers as well. That is out of the pericardium as well onto the surrounding lung parenchyma. That is one mechanism. The another mechanism is that because of increase in the pressure within the left ventricle, end diastolic pressure, subsequently there can be also increase in your left atrial pressure, and subsequently there can be increase in your pulmonary venous pressure, pulmonary capillary pressure, and then that can make the individual to develop pulmonary edema also. Okay, so that is another important mechanism that is being explained why there is development of sudden onset dyspnea. Okay, right. Now the another important clinical features will be, they'll have the features of the reduced cardiac output. What will be that? The features of the reduced cardiac output will be, right, they'll have the excessive fatigability or weakness, then they will have the hypotension, and because of which the cerebral perfusion can be reduced. So the patient will be having discomfort, giddiness, and subsequently they can also have even syncopal attacks as well. And some patients, like with pericarditis causing cardiac tamponade, then they can also have the pericardial pain, right? They can also have the pericardial pain. That is if pericarditis causing the cardiac tamponade. Okay. Now on examination, what will be the very important features? So you have a characteristic pulse that is called pulsus paradoxus, and we have already explained or discussed in detail about what exactly is the pulsus paradoxus, where the fall in the systolic blood pressure is more than 10 millimeters of mercury during inspiration is called pulsus paradoxus. Okay, and regarding this pulsus paradoxus, how do we measure pulsus paradoxus and mechanism of the pulsus paradoxus? I have discussed that in detail in the section of the arterial pulse, right? And what are the other conditions where you will have the pulsus paradoxus apart from that? Apart from cardiac tamponade, it is present in almost 1/3 cases of the constrictive pericarditis. It is also present in the severe forms of the hypovolemic shock, right? Also present in case of the massive pulmonary embolism, can also be present in the severe form of COPD and the severe form of asthma, that is status asthmaticus, right? The word SA stands for status asthmaticus, which is nothing but the acute severe form of asthma. So these are the conditions where you will have pulsus paradoxus. And then you take the JVP. Just now we have discussed JVP will be elevated, right? The X wave, it will be prominent. And what about the Y wave? Yeah, so the Y wave, it will be absent, right? And the JVP which is elevated is non-pulsatile increase in the JVP. So non-pulsatile increase in the JVP, one of the other differential diagnosis is in SVC obstruction. In SVC obstruction also you have the non-pulsatile increase in the JVP. And the another point is the Kussmaul sign is absent. Why the Kussmaul sign is absent? Already we have discussed in the pathophysiology, right? Then what about the heart rate and as well as the blood pressure? So there will be tachycardia, right? Increase in heart rate, and there will be also increase in the respiratory rate as well. And how will be the blood pressure? These patients, they will have hypotension, right, with reduced pulse pressure, because the systolic blood pressure is grossly reduced, so thereby the pulse pressure is also reduced. So in early stages, because of the compensatory mechanisms, the blood pressure may be maintained in early stages, but as the severity increases, these patients, they'll have the hypotension. And the another important point on examination is that these patients, they'll have profuse sweating, that is they have diaphoresis. Along with that, just now we have discussed the heart rate and as well as the respiratory rate will be increased. Tachypnea is there and there is also tachycardia. And because there is hypotension in these individuals, right, when you examine the extremities, there will be very cool extremities. And you will also notice that there is presence of the cyanosis, right? There is also presence of the peripheral cyanosis. And because cerebral perfusion is reduced, these patients, they have depressed sensorium, right? These patients, they have depressed sensorium, right? So these will be the features on the examination. And what is the very close differential diagnosis for the cardiac tamponade? The very close differential diagnosis for the cardiac tamponade is right ventricular myocardial infarction, right? Even this also may resemble the cardiac tamponade. Why? Because even in RVMI, the patient will have the hypotension, right? The blood pressure is reduced. And what will happen to the JVP? The JVP, it will be elevated in case of the RVMI. And even in case of the RVMI, there is absent Y wave in the JVP, right? And occasionally, rarely, there can be a paradoxical pulse. Okay, so this will be the close differential diagnosis for the cardiac tamponade. And the another important differential diagnosis for the cardiac tamponade is the constrictive pericarditis, right? So how will you differentiate from cardiac tamponade from the constrictive pericarditis is that in case of constrictive pericarditis, you have the early diastole which is being present, right? And the later part of the diastole is impaired in case of the constrictive pericarditis. But in cardiac tamponade, it is not like that. So the entire diastole is completely lost. Okay, it is complete diastolic collapse of the ventricle, right? In cardiac tamponade, that means from the beginning itself, the diastole is being impaired in case of the cardiac tamponade. Now, if you see some of the differentiating features between constrictive pericarditis and as well as the cardiac tamponade, you take the paradoxical pulse. It is always present in patients with cardiac tamponade, but it is present only in 1/3 cases of the constrictive pericarditis, right? And equal right and as well as the left-sided pressures. The equal right and left-sided pressures are present during the diastole in cardiac tamponade, and to certain extent, even they are present even in case of constrictive pericarditis as well. Now, what will happen to the systemic venous morphology? Systemic venous morphology, I said you, the Y wave is absent in case of the cardiac tamponade. But whereas in case of constrictive pericarditis, you have prominent X and Y descent. Because of prominent X and Y descent, the morphology of the systemic venous morphology in case of constrictive pericarditis, it will be M or of W shape. Okay. Now, what will happen to the inspiratory change in the systemic venous pressure? Systemic venous pressure, it is decreased, right? The systemic venous pressure will be decreased during inspiration. Why? I have already discussed. Because the interventricular septum is being shifted onto the left side. So systemic venous pressure during inspiration, it will be decreased, right? Whereas it is increased in case of constrictive pericarditis. And that is the reason why you have the presence of the Kussmaul sign here. And what about the square root sign? It is absent in case of cardiac tamponade, whereas present in patients with the constrictive pericarditis. What is square root sign? We have discussed in detail in the section of the constrictive pericarditis. Basically, it is the cardiac catheterization finding of the ventricular pressure changes. That is what will give you the square root sign. So this is about the differential diagnosis of cardiac tamponade. One is RVMI, the other one is constrictive pericarditis. Now, then how will you differentiate that? The very important is the diagnosis. So in the diagnosis, what is the first line and the standard method of non-invasive investigation? The standard non-invasive method for detection is the two-dimensional echocardiography. So within the two-dimensional echocardiography, you need to examine under the M mode and you need to examine under the Doppler study. Okay, Doppler echocardiography has to be done. Now, let us just discuss in detail about the echocardiographic finding, because see, the immediate treatment of the cardiac tamponade, it is life-saving in the individual. So that is the reason why with the help of the 2D echo, you need to establish a prompt diagnosis, right? And that is the easily available diagnostic investigation also. So if you take the Doppler studies in the echo, right, what will happen to the tricuspid and as well as the pulmonic flow during inspiration? The tricuspid and pulmonic flow during inspiration, that will be increased, right? It will be increased. We have already explained the mechanism and the reason. That is because of the shift of the interventricular septum to the LV, there is increased flow to RA and RV and even into the pulmonary artery. So there is increased pulmonic and as well as the tricuspid flow, okay, during inspiration. Then what will happen to the mitral and aortic flow during inspiration? The mitral and aortic flow during inspiration, it will be decreased, right? And the very important point in the cardiac tamponade is there will be late diastolic inward motion. Normally during the diastole, there should be outward motion. There is late diastolic inward motion of right atrium and as well as the right ventricle. Okay, right? Now, let me just show you that image as well. Okay, you see here. So, this is the pericardial effusion or the cardiac tamponade. So, there will be inward movement of, so this is the diastolic phase, right? So, during the diastolic phase, you can clearly observe that there is inward movement of the right atrium and as well as the right ventricle, and that happens during the later part of the diastole. Now, why not the left atrium and left ventricle? Because left atrium and left ventricular pressures, they are slightly higher compared to that of the right side. So, that is the reason why your right atrium and right ventricular inward movement will be there, that we literally call it as collapse, right? This literally we call it as collapse. So, there is inward movement of the right atrium and right ventricle during the late diastole. Now, apart from that, the thing that you will notice is, see, this is the visceral pericardium and this is the parietal pericardium and this is the lucent area, right? So, this view is nothing but parasternal long axis view. So, in the parasternal long axis view, you will be able to observe the lucent separation, right? You will be able to observe the lucent separation between the parietal pericardium and as well as the visceral pericardium, right? Throughout the entire cardiac cycle, you will be able to observe that lucent separation, okay? So, if there is a small effusion, so this particular small effusion, where it will get accommodated first? First, it is evident over the posterobasal part. right? First, it is evident over the posterior-basal part of the left ventricle. That is the area where if it is small effusion, first it gets accommodated. After the posterior-basal part of the left ventricle, then the fluid it accommodates, it subsequently goes anteriorly, then it progresses, right? It progresses laterally, and then subsequently it moves behind the left atrium, right? Subsequently it moves behind the left atrium. So this is what is the sequence of the accumulation of the fluid in the pericardial effusion or cardiac tamponade. First it accumulates in the posterior basal area, right? Now you take the circumferential effusion, right? That is the loculated effusion. Depending upon the quantity of the fluid, we classify that into small, moderate, and as well as the large. When do you call it as the small circumferential effusion? When the echo-free space during diastole, right? Circumferential accumulation means it is the fluid which is accumulating throughout the circumference of the heart, right? Not only posterobasal, even anterior, lateral, inferior, everywhere. So if the echo-free space during the diastole, if it is less than 10 mm, we call it as the small circumferential effusion. If the echo-free space, if it is in between 10 to 20 mm, then we consider it as moderate circumferential effusion. And if the echo-free space is more than 20 mm, then we consider it as the large circumferential effusion. Okay, right. So this is about the how will you assess small, mild, moderate, or the large effusion. Now within the effusion, if you notice that there is frond-like and shaggy appearance in the pericardial space, that tells that there is presence of the clots. That tells that there is chronic inflammation within the pericardial space. That tells that there is neoplastic, right? Neoplastic pericardial processes are going on. Okay, so that is about if there is presence of frond-like and the shaggy appearance. All right, now then followed by that, the diagnosis of the loculated effusion. See, the diagnosis of the loculated effusion, it may not be very clear in the 2D echo, but if you want to visualize the loculated effusion thoroughly, then the best investigation for diagnosing the loculated effusion is the CT or the cardiac MRI. And the other method is by transesophageal echocardiography. So transesophageal echocardiography, CT or cardiac MRI may be necessary to diagnose the loculated effusion, which is responsible for cardiac tamponade, right? Then after this echo will be definitely a best non-invasive investigation for diagnosing cardiac tamponade. Then the next investigation is the electrocardiography, right? First of all, patient will not be able to lie down in the supine position comfortably in case of cardiac tamponade, because the individual will having very severe dyspnea in supine position. The individual will feel to sit down, right? That is what will be the comfortable posture of the individual. So if at all, if you do electrocardiography, what will be the features, right? So you will notice that there will be low voltage complexes. Okay, why? Because there is fluid in the pericardial space that will reduce the conduction of the electrical activity onto the surface of the chest, and thereby the complexes will be small, right? Low voltage complexes will be there. And what exactly is the criteria for low voltage complexes? The amplitude of your QRS complexes in the limb leads, it will be less than 5 mm, whereas the amplitude of the QRS complexes in the chest leads will be less than 10 mm. Okay, that is what is the amplitude of the low voltage complexes, right? Whereas another very important finding is the presence of the electrical alternance, right? The presence of electrical alternance. So electrical alternance is that one complex will be small, the next complex will be large. I'll show you that. So this is what is your electrical alternance. So you have a large complex and then you have a small complex. This is what is called electrical alternance. Why do you get this? Why do you get this is because the heart within the pericardial space in case of cardiac tamponade, it will be swinging anteriorly and posteriorly. When it swings anteriorly, more electrical activity is picked up by the chest leads, and thereby you get a large complex, right? And when it swings posteriorly, the electrical activity which is being picked up is less, and thereby you get the small complexes, and this we call it as the electrical alternance. Okay, right? This is about the ECG. Now, the next important investigation is the video perioscopy. Right? When you want to do video perioscopy, that scope you have to pass through a small subxiphoid incision. Right? Through a small incision in the subxiphoid area, you need to pass this particular scope. And the usage of this video perioscopy is that you will be able to do the biopsy of the tissue, if at all, if any tissue is present. And the another advantage is it is also useful for the drainage of the effusion. That is the purpose of doing the video perioscopy. Actually, we do this in order to make out what is the diagnosis. Okay. And now once you take out the fluid, you need to do the fluid analysis. Right? You need to do the fluid analysis. So if you take this pericardial fluid, in general, it has the features of the plasma ultrafiltrate. And in majority of the cases, the pericardial effusion or the cardiac tamponade, whichever is occurred, it is exudate, right? It is exudate, right? Very rarely it will be the transudate, right? Very rarely it will be transudate. And if you observe the cells in the pericardial fluid, predominantly they are lymphocytes, right? And you have to send the fluid for the routine measurements. What is that routine measurements you have to check for? You have to check for the WBC count. You have to do the differential count. Okay. And third, you need to examine or you need to measure the hematocrit. And you also need to look for what is the protein content. Right? You also need to look for what is the protein content. So that is about the routine measurement, that routine analysis that you need to do. Now, if the fluid is sanguineous fluid, that means bloody tap is there. Okay. So if it is sanguineous, it does not necessarily indicate the active bleeding. It does not tell you that there is some active bleeding ongoing. No. If there is presence of the bloody fluid, that tells the individual might be having an underlying neoplasm. Right? That tells the patient might have developed the chronic renal failure. That tells the patient might have undergone some cardiac injury. So that is what is the importance of the presence of the sanguineous fluid. And if there is chylous effusion, what does this tell you? This can occur after the trauma, right? This can occur after a surgical injury. Okay, chylous effusion means the presence of the lymph, right? Surgical injury to what? Surgical injury to the thoracic duct, right? This can cause the presence of the chylous effusion, right? Or even it could be obstruction, right? Even it could be obstruction of the thoracic duct. Even that can also cause the chylous effusion. Whereas if you take the cholesterol rich effusion, right? Where do you have cholesterol rich effusion is in patients with the hypothyroidism. In patients with hypothyroidism containing cholesterol rich effusion, when you take out the fluid, what will be the color of the fluid? It will be like a gold paint. Okay, yellow color, right? Then the another important thing in the analysis of the fluid is the staining and as well as the culture. Okay, so you have to stain the fluid and you need to do the culture of the fluid in order to examine the presence of which bacteria is causing the pericardial effusion, or is it like fungi causing pericardial effusion. So for that purpose, you need to do staining and as well as the culture. Okay, and the next important is you need to examine for the presence of the malignant cells, right? Because if it is a bloody tap, if it is like bloody fluid, then you have to examine for the malignant cells, which you will be able to make out what are those, like present, is it like mesothelial cells? Okay, and you also need to look for the tumor markers, because certain malignancies of the breast, it is metastasizing and causing cardiac tamponade. So you also need to select the tumor markers for diagnosing what is the cause for the cardiac tamponade, right? And the analysis of the tuberculosis. Okay, that is a very, very important thing. So in which you need to measure the ADA, that is adenosine deaminase. You need to check for the interferon gamma, right? And you also need to do the TB-PCR, that is polymerase chain reaction. So ADA, it stands for adenosine deaminase. In case of tuberculous pleural effusion or tuberculous pericardial effusion, the ADA levels will be elevated. That tells you that there is tuberculous pericardial effusion if the ADA levels within the pericardial fluid, if it is elevated. Okay, now, so after having discussed about how to work up and how to diagnose pericardial effusion or cardiac tamponade, now let me discuss in detail about the treatment of the cardiac tamponade. So if you see the treatment in these patients with the cardiac tamponade, the treatment of choice is definitely the pericardiocentesis. Okay, so if large effusion is present or if there is development of the cardiac tamponade, the pericardiocentesis should be performed. Okay, or you have to watch carefully in cases of the large pericardial effusion whether the individual is going into a state of cardiac tamponade or not. Okay, so otherwise the treatment of choice is the pericardiocentesis. So what you have to do, until unless if the individual is like a terminal case, okay, where there is no prolongation of the life, for example, you take in case of malignancy, except for those, the other patients, you admit the patient to the hospital, you need to do careful hemodynamic monitoring and echocardiographic monitoring, they are mandatory. Okay, hospital admission is mandatory. Now, if you take this pericardiocentesis, for doing pericardiocentesis, you know, there are multiple approaches. You have like subxiphoid approach, you have apical approach and the parasternal approach. But the best approach is the subxiphoid approach, okay, right? And most of these patients, they require pericardiocentesis for the treatment of the cardiac tamponade. And what is the approach here? The best approach is the subxiphoid approach. Now, apart from this, do we need to supplement any drugs apart from pericardiocentesis? Like for suppose, if the individual is having mild tamponade, right? There is no exaggerated increase of the pericardial pressure, there is mild tamponade, then in such case, if the patient is having the pericardial pain of pericarditis, then you can give non-steroidal anti-inflammatory drugs and as well as the colchicine. Now, what is the purpose of giving this non-steroidal anti-inflammatory drugs and as well as colchicine for the brief period of time is they have been, right, they have been found to reduce or the shrink effusion rapidly. That is the advantage of giving these NSAIDs and as well as colchicine if the individual is having pain of the idiopathic pericarditis, if there is mild tamponade. Like you see another conditions. If there is mild cardiac tamponade secondary to connective tissue disorders or any inflammatory disorders, then in them, right, you need to give the anti-inflammatory drugs that is in the form of corticosteroid, right? Either you give your NSAIDs, okay, or preferably you give the corticosteroids, that is the prednisolone. Okay, now if there is a small effusion, right, if there is a small effusion, right, what all we can suspect? Multiple etiologies are there. You can suspect possible bacterial infection, or there could be bleeding into the pericardial sac, right, whose effusions are no small, I mean they are like small effusions. Now, in these scenarios, when there is a small effusion, you just require only conservative treatment and careful monitoring, right? These patients, they don't require the pericardiocentesis. And whenever you are planning for pericardiocentesis, then I said you, they have to be admitted in hospital ICU, then hemodynamic monitoring before the pericardiocentesis, during the pericardiocentesis and after the pericardiocentesis is also very, very important. Now, what is that in the hemodynamic monitoring you will be doing? You need to measure the central venous pressure, that is jugular venous pressure, and you need to place the pulmonary artery pressure catheter, that is balloon catheter, and you also need to measure the pulmonary artery pressure, okay? And you have to do this hemodynamic monitoring especially in cases of threatened cases of the cardiac tamponade, okay? Or like for example, a patient says that I don't want to get the pericardiocentesis done, right? In those patients who are like deferring the pericardiocentesis, in them this hemodynamic monitoring is very, very important. If the hemodynamic monitoring is worsening, immediately you have to tell that the patient is worsening, and then you have to plan for the pericardiocentesis. So monitoring, it is helpful before pericardiocentesis and even after the pericardiocentesis. Like, why is that after the pericardiocentesis? See, after pericardiocentesis, you need to do this hemodynamic monitoring, that is mainly to assess the reaccumulation, right? That is mainly to assess the reaccumulation. You need to do the hemodynamic monitoring. Okay, so the insertion of the catheter in the central circulation, it should not be allowed to delay definitive therapy in critically ill patients. You should not waste your time in the placement of central venous catheter, right? You have to do pericardiocentesis and parallelly you place the central venous catheter. Okay, right? Why? Because your pericardiocentesis, it's an emergency procedure, right? And once you have planned that to go ahead with the pericardiocentesis, then immediately you also need to start the intravenous hydration with the normal saline. Okay, and even you need to give the positive inotropes, and these positive inotropes, they include the norepinephrine. So the basic purpose of that is mainly to increase the blood pressure of the individual. Even though these positive inotropes or IV fluids, they are having limited efficacy, but we need to start them. So volume expansion and as well as the positive inotropes, they are temporary measures actually, right? They are definitely temporary measures. Okay, but they should not be placed as the substitutes, and you should not delay pericardiocentesis. Your hydration and as well as positive inotropes, they are not the substitutes at all, and because you are giving them, you should not delay the pericardiocentesis. Okay, you have to do immediate pericardiocentesis. So pericardiocentesis, it is considered as the treatment of choice, right? And the point is, in majority of the cases, what we do is closed pericardiocentesis. We don't create any thoracotomy, right? We don't create any window, right? Majority of the cases, we do a closed pericardiocentesis. Exceptional cases, right, containing clots, containing fibrous material, right? In these scenarios, when you do pericardiocentesis, the clots and the fibrous material, they may not come through the pigtail catheter what you are inserting there. Okay, so in such case, you need to do, right, you need to go for the open pericardiocentesis, right? So this open approach is very much safety and easy to obtain this clot and as well as the fibrinous material. Okay, now many a times you get confused whether to go ahead with the closed versus the open pericardiocentesis. Okay, because the problem with the open pericardiocentesis is like bleeding. That is what we are very much worried about. So that is the reason why always a point of confusion comes whether to go ahead with the closed or the open pericardiocentesis. Now, okay, what is the disadvantage of the closed pericardiocentesis? The disadvantage of the closed pericardiocentesis is that when you are doing pericardiocentesis, what is that you will be doing? You will be reducing the intrapericardial pressure, right? And once there is reduction in the intrapericardial pressure, what can happen? There can be further bleed, right? There can be further bleed that will be entering into the pericardial space, right? There can be further bleed that will be entering into the pericardial space. Okay, right? So by doing your closed pericardiocentesis, we will not get an opportunity to correct where is the source of the cardiac tamponade. That is the disadvantage of the closed pericardiocentesis. So that is the reason why in cases of trauma or in cases of the rupture of the LV wall, instead of the, where can you have the rupture of the LV wall, right? That is in cases of MI. So in this scenarios, you need to plan for the open pericardiocentesis rather than the closed pericardiocentesis. Okay, not only that, right, if the bleeding is slower, right, if the bleed which is happening is slower, okay, if the bleeding is slower, where can you have the bleed being slower? Like when you are doing a coronary artery procedure and there is a procedural coronary perfusion, then there can be a slow accumulation of the fluid into the pericardial space. In this case, right, then go ahead with the closed pericardiocentesis itself. But when there is trauma or rupture of the LV wall causing rapid accumulation, then go ahead with the open pericardiocentesis. Okay, right. And see, closed pericardiocentesis in patients with bleeding into the pericardial space because of type A dissection, it is contraindicated. Okay, so if it is type A dissection, right, type A aortic dissection, better to go ahead with the open pericardiocentesis rather than the closed pericardiocentesis. Okay, now if you are doing this closed pericardiocentesis, the approach is the subxiphoid approach. Okay, so this is what is your subxiphoid approach. You see here, right, where you have to insert the needle in the subxiphoid area, that is towards the left shoulder, and this particular angle should be 45 degrees. And once you have inserted the needle, first and foremost, what you try to do is you try to take out the fluid. How much fluid you try to take out? Minimum of 50 to 150 ml. You should try to take it out with the help of the syringe. What is the advantage of this? The advantage is that this will cause instantaneous hemodynamic improvement. Right? This will cause removal of 50 to 150 ml. This will cause instantaneous hemodynamic improvement. After that, what you have to do next? After that, what you have to do the next is you have to insert the guide wire through the needle. Right? You have to take out this plunger. Right? You have to take out this plunger. Only needle will be there. Through the needle, you need to pass the guide wire. And once you have passed the guide wire, take out the needle. Guide wire is there still inside. And onto this guide wire, you need to pass this pigtail catheter. Right? Onto this guide wire, you need to pass the pigtail catheter. And whenever you are doing all these, you have to monitor the ECG. Because if you have punctured the heart, if you have punctured the epicardium, immediately you will notice that there is ST segment elevation in the ECG. So, in order to prevent the puncturing of the heart, you need to do close monitoring of the ECG. Right? So, this pigtail catheter, it is being manipulated, and you have to place the pigtail catheter in the area where the maximum fluid is being present. Okay, right? When possible, the procedure should be performed in the cardiac catheterization lab rather than doing under the two-dimensional echocardiographic guidance. Right? It is preferable to do under the fluoroscopy in the cardiac catheterization lab. Right? And whenever you are doing this, you have to do the hemodynamic monitoring. Right? You have to insert the pulmonary artery catheter and you need to monitor the pulmonary artery pressure. You need to monitor right atrial and as well as the right ventricular pressure, and you also need to monitor the pulmonary capillary wedge pressure. Okay. Not only that, you also need to monitor the pericardial fluid pressure as well. And this pericardial fluid pressure, that has to be measured during the procedure, before the procedure, and even after the procedure. Right? After the procedure, once you measure the pericardial pressure, that you need to take it as the baseline pressure. What is the purpose of this? Because once there is reaccumulation of the fluid, the pericardial pressure further increases. Okay, that is the purpose of measuring the pericardial fluid pressure before, during, and as well as after the pericardiocentesis. Right? And strict hemodynamic monitoring has to be followed during the entire procedure. Now, once your pericardiocentesis has been done, you need to do a repeat echo. Right? Why? Because you are seeing the pericardial pressure. So, what should be the duration of this monitoring? The duration of the monitoring, it should be for nearly around up to 24 hours. That will be more than sufficient in order to look for is there any reaccumulation of the fluid in the pericardial space. And what has been recommended is, remember, this intrapericardial catheter, that pigtail catheter, it is placed within the pericardial space itself. Right? We place it for several days. We place it for nearly around 3 to 4 days. Why? If there is any reaccumulation, there will be continuous drainage. Right? So, for this, in order to minimize the recurrence, we will place this pigtail catheter for a few days in the pericardial space itself. So, this is about your closed pericardiocentesis. Whereas, you take the open pericardiocentesis. Just now we have discussed the indications. What is that? Number one, trauma and as well as the rupture of the LV free wall secondary to myocardial infarction. And if it is loculated effusion, once you put a pigtail catheter and take out the fluid, the entire fluid does not come out. So here you need to do open pericardiocentesis if there is a loculated effusion, right? And if there is recurring effusion, right? So recurring effusions also you need to do open pericardiocentesis, right? And then you also have to take the biopsy of the tissue in order to make out what is the cause for the recurrent effusion. Okay, right. So basically what you have to do in case of open pericardiocentesis is you need to create a pericardial window. Right, you need to create a pericardial window. Okay, right. And this creation of the window, this will eliminate the future tamponades, right? This will eliminate the recurrences. That is the advantage of creating the pericardial window. And one more methodology of taking a treatment is the percutaneous balloon technique. Okay, so percutaneous balloon technique have also been used for the drainage of the pericardial fluid. Then what is the indication of this? The method appears to be safe and effective for producing the windows, and it is useful in patients for malignant effusion. Right, in case of malignant effusion, creating this percutaneous balloon technique or creating the window will be of very much use. Okay, thereby what can you prevent is you can prevent the recurrence, right? You can reduce the recurrence. That is the advantage of your percutaneous balloon technique, right? And now by doing this percutaneous balloon technique, the surgery can be avoided. Surgery can be avoided. So this is what is your percutaneous balloon technique. So this is the procedure. What is that? First, the skin entry of the needle should be through the abdomen, right? You need to insert at the abdominal wall. Then you need to do a puncture of the parietal peritoneum because you have entered into the abdomen. And then after puncturing the parietal peritoneum, diaphragmatic perforation or diaphragmatic peritoneum should be punctured. Then anterior aspect of the diaphragm has to be punctured. Then puncture the pericardial fat. Then sternopericardial and pericardiodiaphragmatic ligaments have to be punctured. Then finally you puncture the parietal pericardium and enter into the pericardial space, and then you inflate the balloon. So thereby you get a pericardial window. Very much useful in case of the malignant effusion, mainly to reduce the recurrences, right? And we have a procedure called as pericardioscopy and percutaneous biopsy. So pericardioscopy, what is that you will be doing here is you will pass a scope, right? You will pass a scope directly into the pericardial space, and you will visualize where exactly is the pathology within the pericardium, and thereby you will take the biopsy from that area. Okay, so the routine use of pericardioscopically guided biopsy, it has been advocated in patients with pericardial effusion without causative agent. We don't know what is the causative etiology for cardiac tamponade. In such case, you need to do the pericardioscopy, where you will be able to visualize what exactly is happening in the pericardium, and then you can fix the etiology there, right? So there were some studies also, right? The studies have done, and studies have done the comparison also. In some of them, like they have done the pericardioscopy and to make out the etiology, and in some of them, right, it has fluoroscopic guided biopsy has been done. Okay, so in order to make out the etiology, and what has been found is the pericardioscopy guided biopsy was found to be safe and as well as more efficient than compared to that of the fluoroscopy, right? Then compared to that of the fluoroscopic guided biopsy. Okay, so basically this is a procedure like to make out where to take the biopsy from, which is the best method? Is it like fluoroscopic guided percutaneous biopsy, or is it pericardioscopic guided biopsy, which is best? What has been found is pericardioscopic guided biopsy is best. The indication is like we don't know what is the etiology. In order to make out the etiology, we need to take this particular biopsy. Okay, so this is about your cardiac tamponade. So what all we have discussed in this, right? We have discussed the basic anatomy, right? That is the fibrous pericardium, and then the serous pericardium, parietal and as well as visceral layer. Then the basic physiology, right? We have discussed the stretch tension curve, then pressure volume curve. Then we have discussed the pericardial functions, right? One is lubrication, prevention of the entry of the infection, acting as a shock absorber, right? Multiple functions. Then differences between cardiac tamponade and pericardial effusion. It is the difference is the rapidity with which the fluid is accumulating. Then pathogenesis of the cardiac tamponade. It is basically diastolic dysfunction and diastolic collapse of the ventricles. Clinical features, sudden onset dyspnea, and they'll have the features of reduced cardiac output. Diagnosis, very important, is by your 2D echo, and treatment of choice is pericardiocentesis. Depending upon the underlying etiology, you need to do either closed or open pericardiocentesis. This completes the discussion of this very important topic, that is cardiac tamponade. Thank you very much.